Welcome to This Week in Oncology. This week we are covering 10 notable papers spanning targeted therapeutic strategies in solid tumors, proactive management of resistance in breast and gynecologic malignancies, new insights into hematologic treatment and screening, and advancements in supportive care. Let us dive in. We begin with targeted therapies in solid tumors, featuring new results in thyroid cancer, uveal melanoma, and non-small cell lung cancer. In a global randomized double-blind placebo-controlled phase 3 trial, researchers evaluated the efficacy and safety of combining the BRAF inhibitor dabrafenib with the MEK inhibitor trametinib in adults with radioactive iodine refractory, BRAF-positive differentiated thyroid cancer. The trial randomized 153 patients in a 2-to-1 ratio to receive either the combination or matching placebos. At a median follow-up of over 17 months, the primary endpoint of progression-free survival was significantly longer in the combination group, with a median of 12.8 months compared to just 3.7 months in the placebo group, representing a substantial reduction in the risk of progression. The overall response rate was also dramatically higher in those receiving the targeted combination, at 57% compared to only 4% in the placebo group. However, an interim analysis of overall survival did not achieve statistical significance, and the combination was associated with notable toxicities. Pneumonia occurred in 8% of the combination group compared to 2% with placebo, and serious adverse events were reported in 43% of patients on dabrafenib plus trametinib, compared to 25% of those on placebo, including one treatment-related death due to a cerebrovascular accident. Transitioning to aggressive rare malignancies, Nature Medicine published a phase 1 trial evaluating DYP-688, a novel biology-matched antibody-drug conjugate designed for GNAQ or GNA11 mutant melanomas, such as metastatic uveal melanoma. This agent targets the surface melanocyte lineage antigen PMEL and delivers a potent G-alpha-Q/11 inhibitor payload directly into the cells. In this first-in-human study of 66 patients, DYP-688 was well tolerated, with grade 3 treatment-related adverse events occurring in only about 8% of patients. Preliminary efficacy was encouraging, with an objective response rate of roughly 20%, tumor reduction observed in over 70% of patients, and a median progression-free survival of 7.2 months, highlighting a promising new therapeutic avenue for a disease with historically limited options. In the domain of biomarker-driven care for non-small cell lung cancer, Clinical Cancer Research published an analysis on the clinical significance of baseline EGFR amplification in patients with EGFR-mutated metastatic disease receiving first-line osimertinib. Among 473 patients who underwent baseline next-generation sequencing, 17% had EGFR amplification defined as a copy number of 6 or greater. These patients were more likely to have TP53 co-mutations and baseline metastasis in the brain, liver and bone. While the objective response rate to osimertinib was similar, regardless of amplification status, patients with baseline EGFR amplification experienced a significantly shorter median progression-free survival of 11.6 months compared to 19.0 months in non-amplified cases, as well as a shorter overall survival. Furthermore, upon developing resistance to osimertinib, patients with baseline amplification more frequently showed acquired MET alterations, suggesting that these patients may benefit from upfront combination strategies rather than osimertinib monotherapy. Our second theme addresses the proactive management of resistance and recurrence in breast and gynecologic cancers. In breast cancer, the Lancet Oncology published an extended analysis of the phase 3 SERENA-6 trial, which is the first registrational study to use prospective circulating tumor DNA monitoring to detect resistance mutations and direct a change in therapy before clinical progression. The trial focused on patients with hormone receptor-positive, HER2 negative advanced breast cancer receiving first-line aromatase inhibitors plus a CDK4/6 inhibitor. When an ESR1 mutation was detected in circulating tumor DNA during routine surveillance, and in the absence of radiological progression, 315 patients were randomized to either switch to the oral selective estrogen receptor degrader camizestrant or continue their current aromatase inhibitor, both with continued CDK4/6 inhibition. Switching to camizestrant significantly improved progression-free survival, demonstrating that molecularly driven proactive treatment switches can successfully delay clinical progression. For patients experiencing recurrence in gynecologic oncology, the Journal of Clinical Oncology published the updated ASCO Living Guideline for the systemic treatment of ovarian cancer recurrence. Drawing on evidence from 147 publications, the expert panel updated recommendations for high-grade serous or endometrioid epithelial ovarian, fallopian tube, or primary peritoneal cancers. For platinum-sensitive recurrences, clinicians should offer platinum-based combination doublets, specifically pegylated liposomal doxorubicin plus carboplatin, paclitaxel plus carboplatin, or gemcitabine plus carboplatin, with the optional addition of bevacizumab followed by bevacizumab maintenance. For platinum-resistant or refractory disease with validated folate receptor alpha expression, the antibody-drug conjugate mirvetuximab soravtansine is now strongly recommended. Other systemic options for platinum-resistant disease include pegylated liposomal doxorubicin monotherapy, weekly paclitaxel, bevacizumab in combination with chemotherapy, or the combination of relacorilant and nab-paclitaxel. Notably, the guideline notes there is currently insufficient evidence to routinely recommend secondary cytoreduction or hyperthermic intraperitoneal chemotherapy, though cytoreduction may be discussed for platinum-sensitive recurrences, where complete gross resection is highly achievable. Our third theme explores hematologic malignancies, highlighting maintenance therapy, screening outcomes, and the clinical reality of negative trials. In the Journal of Clinical Oncology, a secondary analysis of the Phase 3 TRIANGLE trial evaluated the benefit of adding rituximab maintenance to ibrutinib-containing regimens for younger untreated patients with mantle cell lymphoma. While the primary trial established ibrutinib-containing therapy without autologous stem cell transplantation as a new standard of care, the role of rituximab maintenance remained undefined. This analysis included patients who responded to induction therapy, comparing those who did and did not receive maintenance. The addition of rituximab maintenance significantly prolonged 4-year progression-free survival, improving it from 73% to 85% in the non-transplant arm, and from 75% to 90% in the transplant arm, with trends toward prolonged overall survival. However, this benefit came with a substantial increase in grade 3 to 5 infectious toxicities, which rose from 11% to 34% in the non-transplant group, and from 18% to 41% in the transplant group, demanding careful patient selection and monitoring. In contrast, the Phase 3 ENHANCE study also delivered disappointing results for patients with higher-risk myelodysplastic syndromes. This trial evaluated the addition of the anti-CD47 antibody magrolimab to azacitidine compared to placebo plus azacitidine in 539 treatment-naive patients. The study failed to meet its dual primary endpoints. There was no significant difference in complete remission rates, which were 21.3% with magrolimab and 23.6% with placebo. Furthermore, median overall survival was actually shorter in the magrolimab arm at 15.9 months compared to 18.6 months in the placebo arm. The magrolimab combination also led to a significantly higher incidence of serious adverse events and treatment discontinuations, reinforcing that this combination should not be used in clinical practice. Moving from treatment to early detection, the Journal of Clinical Oncology published the clinical and psychological outcomes from the nationwide iStop-MM screening study in Iceland. Over 75,000 individuals were screened for monoclonal gammopathy of undetermined significance, and those diagnosed were randomized to no notification, guideline-based follow-up or intensive follow-up. After a median of 4.5 years, screening led to a 27-fold increase in the detection of smoldering multiple myeloma. While active malignancy rates did not differ overall, active multiple myeloma and related malignancies were diagnosed an average of 1 year earlier in the active follow-up arms, leading to fewer symptomatic presentations and fewer hospitalizations at the time of diagnosis. Reassuringly, notifying patients of their diagnosis did not result in adverse psychological outcomes, supporting the feasibility and safety of early screening and proactive monitoring. Our final theme focuses on supportive care and lifestyle interventions, which are critical for maintaining treatment intensity and quality of life. The Journal of Clinical Oncology published the Phase 2 ACTGI trial, evaluating the second-generation oral thrombopoietin receptor agonist, avatrombopag, for persistent chemotherapy-induced thrombocytopenia in patients with gastrointestinal cancers. Persistent thrombocytopenia is a frequent barrier to maintaining full-dose, on-time chemotherapy. This double-blind randomized United States-based trial compared avatrombopag to placebo and was stopped early for efficacy at a planned interim analysis. 70% of patients receiving avatrombopag successfully corrected their platelet counts to at least 100,000 per microliter and prevented recurrence without requiring chemotherapy dose modifications or delays, compared to only 17% in the placebo group. No serious adverse events were related to the study drug, demonstrating that avatrombopag is a highly effective, safe oral option to manage this challenging complication. Finally, addressing lifestyle modification, the ECOG Akron EAQ171CD randomized trial, also in the Journal of Clinical Oncology, evaluated a virtual sustained tobacco treatment program for patients recently diagnosed with cancer. The trial compared a telehealth delivered program consisting of up to 11 counseling sessions and up to 12 weeks of free nicotine replacement therapy against enhanced usual care, which consisted of a referral to the National Cancer Institute quit line. The virtual sustained treatment nearly doubled the 6-month quit rate, achieving a 28.4% abstinence rate compared to 14.7% in the usual care group. The intervention was highly utilized and cost-effective, with an incremental cost of $7,724 United States dollars per quit, supporting the integration of remote tobacco cessation programs directly into community oncology practices. If you only have time for one paper this week, make it the extended analysis of the SERENA-6 trial. This study represents a paradigm shift in breast cancer management, proving that prospective circulating tumor DNA monitoring can identify resistance mutations early and guide proactive therapy changes to delay clinical progression before it is visible on a scan. Here are the key takeaways from this week in oncology. First, in patients with radioactive iodine refractory, BRAF positive differentiated thyroid cancer, the combination of dabrafenib and trametinib significantly extends progression-free survival, though clinicians must remain vigilant for toxicities such as pneumonia. Second, adding rituximab maintenance to ibrutinib-containing regimens in younger patients with mantle cell lymphoma improves long-term progression-free survival, but carries a significantly higher risk of severe infectious complications. Third, the Phase 3 ENH-ANCE trial confirms that adding magrolimab to azacitidine does not benefit patients with higher-risk myelodysplastic syndromes and increases severe toxicity, indicating it should not be utilized. Fourth, for patients with gastrointestinal cancers experiencing persistent chemotherapy-induced thrombocytopenia, the oral agent avatrombopag is highly effective at restoring platelet counts and preventing treatment delays. And finally, implementing virtual telehealth counseling combined with free nicotine replacement therapy can double smoking cessation rates among recently diagnosed cancer patients in community oncology settings. That's your roundup for this week in oncology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.